Good morning, everyone. So this is Becky. So thank you for joining us today on our Q&A on capnography, which will be presented by Ellie West, our anaesthetist and sustainability lead. We've had a couple of questions come in already, and Ellie's going to kindly do a short presentation as well, just a bit of a recap for you all. For those who haven't used Teams before or done a live event, if you do have a question at any point, if you would like to just top right hand corner, there's a little speech bubble with a question mark in it. If you would like to pop your questions in there, and I can read those out to Ellie and she'll answer those at any point through this, so please feel free to pop those on there, and they can also be done anonymously if you would rather. So without further ado, I'll hand over to Ellie for you. Thank you, Ellie.
Hi everyone. Becky, can you still see the PowerPoint presentation there?
Yep, that's all good.
Excellent. I apologise to everyone. There was a choice on Teams this morning between showing you the presentation and showing you me, and you couldn't have both. So this morning I thought I'd give you the presentation instead. And as Becky said, please stick any questions up. Really, this session is for you guys. I am at home, as I'm sure many of you are at the moment. So this is just an opportunity to touch base, really. All right, let's move on the slide if it will do so. So I just wanted to give you a bit of background as to how this has all come about. My interest in capnography is partly as an anaesthetist, and I work at Davies Veterinary Specialists, but also because I've had a burgeoning interest in sustainability over the last few years. And I hope to show you sort of the links, although if you've watched the webinar, you've already got an idea. So we have been putting out resources from Davies on sustainability for a while, and I've got the picture of the waste posters there. But then COVID came, and we realised that we were going to need to provide people with some information on how to conserve oxygen. And so we put out these infographics on and this blog, and all of that is available through the Davies website. And so there's a webinar, and there's a FAQ document, and a kind of blog that gives you information on how to reduce your oxygen flow safely. And as we were writing that, I thought, oh crikey, the next thing's going to need to be capnography. We need to kind of help people with that as well. So we put out the fact sheet. Again, those resources are all available through Becky Timmons, through the Davies website, and if you're a Linnaeus practice, then through the Linnaeus General Webinars section. And we will, so we've done the webinar, we've done the fact sheet, and we'll be doing frequently asked questions will be coming as a sort of separate document, mostly based on today, really. Just my musings on capnography to add to what Becky Robinson has done in the webinar, which I hope you've had a chance to watch. It is a much favoured monitor amongst anaesthetists. If you talk to specialist anaesthetists, they'll pretty much all want to work with capnography. It's required for medical anaesthesia. It's in their guidelines that you have to have a capnograph. The thing to bear in mind with it is it's exquisitely sensitive, but it can mean so many different things, which is I think where the confusion can happen with it. So a little bit of learning about it comes from just experience, but you can build up that experience pretty quickly, and the common things are common. I just wanted to highlight, of course, we never panic. But these are capnograms under which I might move quickly or allow myself a micro period of panic. So these are all in the infographic for capnography again, but I just wanted to highlight them to say cardiac arrest is this stepwise reduction in CO2, expiratory obstruction, and that can be for a number of reasons. It can be bronchospasm, it can be a mucus plug in your ET tube, it can be the ET tube wedged against the side of the trachea. It has this classic shark fin look, so that is a cause for immediate concern. But I just wanted to highlight emboli, because gas emboli, thromboemboli, all sorts of different emboli, cement emboli, if you're doing things like total hip replacements, they will cause this stepwise, not a stepwise reduction, but a step reduction, but then it tends to stay at the lower level. So that's how you can differentiate often from cardiac arrest, is you get this sudden reduction from the 40s to the late teens of end tidal CO2, but then it tends to stay there. And if it's an air emboli, then gradually that air gets resorbed and the CO2 will come back up again. But obviously in the acute instance, you see this massive reduction in CO2 and you think, crikey, they're arresting. And the clue is then that you go and you check the pulse and you check the other recording parameters, and they all seem to be okay. And you think, I'm doing a surgery where an emboli is possible. So that's just to highlight those, but those three are the ones that I really watch out for. I wanted to touch on sustainability because this is going to be a drive in the future. It's something that we should use capnography to come out of this crisis healthier. Anaesthetic agents, all of the volatile anaesthetic agents and nitrous oxide are greenhouse gases. Some of the agents, mostly nitrous, are also ozone depleting. And we release a fair amount of these anaesthetic agents every year, to the point where the medical anaesthetists are even putting an editorial out saying we're abandoning, not even should we abandon, but how do we go about abandoning inhalational anaesthesia? So, these are all big questions that we need to answer. And I put the infographic there, that was in the webinar as well, just to say that if you use a whole bottle of isoflurane, the gas emissions that vapour causes is equivalent to driving from Plymouth to John O'Groats. So fairly significant. Some are worse than others. The global warming potential, GWP, is a value that people use to sort of give you an equivalent. So carbon dioxide comes up as a GWP of 1. Carbon dioxide is bad. It's just that these guys are worse. Now, obviously, we don't use as much, let's say, of isoflurane as we do of sevoflurane because of the difference in potency. But you can see that desflurane is incredibly high GWP, plus it's not a very potent drug, so you need a lot of it, so that's a particularly damaging one. Nitrous is less than isoflurane, but you need a lot more nitrous in order to provide a clinical utility. So actually nitrous has a much bigger effect because we're using per volume a far greater amount of it. I've put these links underneath to podcasts. If you click on those, they should take you to the hyperlinks. Those are freely available at the moment. Just to give you an idea, if you do 30 kilo dog for cruise ship surgery, and I have Tom Pearce of the Royal College of Anaesthetists to thank for this carbon calculator. So we're assuming that you're using a fairly standard protocol, you're pre-medding appropriately, you're doing a nerve block with a local anaesthetic, you're inducing with propofol, and yet the footprint of your anaesthetic will be about this much nitrous, this much iso, and this much energy for doing things like ventilating the theatres, providing lighting, allowing staff to commute to work. So you can see that if you can reduce your nitrous oxide use, and I would actually say eliminate your nitrous oxide use, and find ways of reducing your ISO, then you'll reduce a fairly large proportion of your footprint from a volatile anaesthetic procedure. So how can you use capnography to get sustainability? And this is all in the webinar again, but I just recap and say, if you can reduce your fresh gas flow when you're using a non-rebreathing system to only just prevent rebreathing of CO2. So you could turn your fresh gas flow down until you see this sort of capnogram, and then turn your fresh gas flow up until you get your normal capnogram where the inspiratory CO2 comes down to baseline, which is where it should be. So if you're just tweaking, rather than calculating a fresh gas flow based on an assumed minute ventilation for an average animal, you can use your capnograph to titrate the fresh gas flow to exactly your patient. And that'll allow you to reduce your amount of volatile anaesthetic, but also to increase it when necessary as well, because if you see rebreathing on a non-rebreathing system, you need to increase the fresh gas flow. On a rebreathing system, your capnograph helps you ensure that the system is functioning so that you haven't got soda lime exhausted or valves not working, or your patient isn't breathing well or coping with resistance of the system, that you've got leaks, that your patient's accidentally extubated, or maybe that you've got excessive dead space. Your capnograph helps to pick out all of those things. And again, that's all in the oxygen conservation blog as to how to achieve that and how to use the lower flows safely. So I want to kind of open to the floor. This is a woodland floor, an ancient woodland floor, because you can see wooden anemones there. They're out at this time of the year if anybody's out and about on their daily exercise looking for them. We're open to questions about the capnography webinar that you should have had access to, or questions about capnographs in general. Any questions about sustainability, actually in general or specifically to do with anaesthesia, and quite frankly any random questions about anaesthesia, because I'm here for you, and if we have more questions than we can deal with today, we will be producing a written list of the questions with answers. We can run further webinars along this theme or along other themes. Just let Becky Timmons know. And we will be running, we have got a planned series of webinars for general practice, first opinion vets and vet nurses coming out. So I'll open to Becky, if you wouldn't mind feeding me questions, because I don't think I can see them at the minute.
Absolutely. So just a reminder to anyone who wasn't at the very beginning. So any questions, top right hand corner, a little speech box with a question mark in. If you pop your questions in there, and I can read those out to Ellie. I did have a couple come through on email to begin with, Ellie. So how much CO2 is too much CO2?
So it's a really good question, because we know that normal Capnograph, if I just close this so that you can see the infographic that we made, a normal CO2 should have an end tidal CO2 value of between 35 and 45. So, and a normal capnogram should look pretty much like this. So this is where your end tidal value should sit. So that end tidal value is the number that the capnograph will normally read out. It should be between 35 and 45. And anything over 45 is classed as high CO2. And so the question is, you have anaesthetized your patient, which means that you've given them, on the whole, drugs like volatile anaesthetic agents, which are poisons. They're poisons to the cardiovascular system, they're poisons to the brain, which is good in a way because it makes them asleep. So it's a titrated poison, but it's also a poison to the respiratory system. So you're going to, in many cases, see hypoventilation and as a result, hypercapnia. So if you get to the sort of levels of, let's say, 90 to 100 millimeters of carbon dioxide, you're heading towards the place where carbon dioxide can act as an anaesthetic agent in its own right. And in fact, carbon dioxide is used as a pre-slaughter stunning drug. So they'll have these wide cages with sealed at the bottom, and carbon dioxide is a heavy gas, and you can pump the gas in and the animals will become unconscious in a matter of really seconds. So we don't want to be getting to the stage where CO2 is an anaesthetic agent in its own right. That's the first thing. So the question is, when does it start happening? And actually, it will happen in a graded response. But when you get to that sort of very high levels, then you have got a vicious circle happening, because you're trying to, your patient's not ventilating well because they're anaesthetized, but they're anaesthetized because of they're not ventilating well. So you don't want to get anywhere near that. From equine studies, we know that CO2 can act as a sympathetic stimulant. So it acts a little bit like a kick of adrenaline. And we know that adrenaline will give you an increase in heart contractility, an increase in heart rate, as a result, an increase in blood pressure. And again, these are subtle effects. As you get higher, they may have more of an effect. So sometimes you've got a patient that looks very deep and they're tachycardic. And it could be because they're vasodilated because they've got too much isoflurane, too much anaesthetic agent, and they're tachycardic as a baroreceptor reflex response. Or it could be because the CO2 is high, and just occasionally you'll have a patient that is got high CO2, is tachycardic, you ventilate them, bring the CO2 down, and the heart rate stabilizes. Now, on the whole, they're probably hypoventilating because they're too deep, and actually the treatment is just to turn the anaesthetic agent down rather than ventilate. So if you're finding that you're heading upwards, it may not be an awful thing to have a higher CO2, because it might just give you a bit of this adrenaline kick. So you might say, well, okay, that's good. But I think that what you should be looking at is, as your CO2 rises, this is an indication that your patient is not breathing well. And you say, well, is there anything I can do to make that patient breathe better? Can I turn the anaesthetic agent down? Or have I just given a drug like methadone or fentanyl, an opioid, which reduces ventilation? And am I expecting a little bit of an increase in CO2? So what we say to our nurses is, if the CO2 is at 55, give us a shout. Because at that point you may need to make an adjustment to your anaesthetic, turn your anaesthetic agent down, or you may need to make a decision about ventilating. And there may be some situations where you let them sit in that sort of 55-60 region. Classic would be brachycephalics. We wonder whether brachycephalics have a higher set point for CO2 because they struggle to breathe most of the time. So they end up with a normal CO2 stimulating them to breathe at that sort of level. So we normally say 55, give us a shout, start making some decisions. If they're happily sitting at 50 and breathing well otherwise and every other parameter stable, they're at an adequate depth of anaesthesia, you don't want to turn them down because you're about to do a more invasive or more stimulating part of the surgery, then we let them sit there. So I think when you're getting towards upwards of 70, then I definitely ventilate whilst I'm fixing things. So 65, 70, probably start ventilating. 55 up to that sort of level, might let them sit there. Now, sorry, this is a long answer. The only caveat to that is if you have a patient with any kind of head injury, any potential for raised intracranial pressure, any neurologic disease that might affect their ability to ventilate, or their what's the word, or might result in a raised intracranial pressure, then you need to keep that CO2 down, and you need to keep it probably between about 35 and 40, because one thing that CO2 can do in the brain is expand the blood vessels in the brain, which will increase the pressure. So in a patient with head trauma, absolutely keep the CO2 down. You might know that you've got a patient that can't ventilate. You might have a diaphragmatic hernia, in which case you may as well ventilate them from the start. So I'll stop waffling there in case I'm going off on a tangent from the question.
Thank you, Ellie. And second question I had was, when do you need to ventilate?
Yeah, so I guess this sort of segues from the first question, really. I think we have to remember that ventilation is not a benign intervention. So when you provide positive pressure ventilation, that is the opposite of the way that the body wants to naturally breathe, which is a negative inspiratory pressure. So you suck the breath in and you suck the lungs open using your rib cage and your intercostal muscles in your diaphragm. So normally when you breathe in, there's a negative pressure in the pleural space, whereas when you are providing ventilation for a patient, you're pushing the air in, and that has a positive pressure effect within the thoracic cavity when you're ventilating. And the problem with that is that it puts a little bit, it changes the dynamics of the blood flow into the chest a little bit. So if you're putting positive pressure in, it stops blood coming back into the thoracic cavity, back to the heart, essentially. So it prevents venous return. And an effect that will have is it will reduce cardiac output. Now, most of our patients, you'll get away with blue murder. They'll be absolutely fine when you ventilate. But some of your patients won't cope particularly well with that, especially if they've already got some degree of cardiovascular compromise. The other times it's not a good idea to ventilate is if, let's say, you've had, I don't know, a RTA in the past sometimes, and unbeknownst to the poor anaesthetist, there's a lung bulla or a lung bleb there. And by providing positive ventilation, you can actually pop those blebs. So it's worth thinking or looking in the histories for animals if they've had an RTA in the past, just bearing that in mind. The other thing is if you are masking one evil with another, so if your patient is hypoventilating because they're too deep under anaesthesia, and you say, well, I'll just ventilate them, then actually you've got two problems now. You've got the reduced cardiac output from ventilating, and your patient is too deep. So the effect on your blood pressure is likely to be a double whammy. So so in that situation, the sense would be to turn the isoflurane down, which is, 9 times out of 10 the result of a small animal patient having low blood pressure and hypoventilating. So bearing in mind that ventilation can have some side effects that we don't necessarily want, when do you need to ventilate? I think if they're sitting happily with a CO2 of 55 and everything else is normal and you have no risk of head injury or worry about that, fine. I'm reasonably comfortable to sit at that sort of level. Somebody's going to shout and say, but what about, and please do, because that'll be the obvious thing that I've forgotten to say. But if they are heading upwards of 60, 65, 70, I think that you are heading towards the point where CO2 becomes an anaesthetic agent, potentially. And I would be looking in those patients to ventilate them whilst I deal with the underlying problem. So it might be, let's say, I gave the example of giving a dose of fentanyl. We expect that to last for 20 minutes, or a dose of ketamine. And those can sometimes cause a transient apnea, or indeed a dose of propofol. You get a transient apnea sometimes. Those patients are not going to breathe while that drug is in its maximum effect. So until that drug is redistributed, they're not going to breathe. So you need to ventilate. But if you have just given a dose of fentanyl, patient's still breathing, but the CO2 has gone from 45 to 50 or 50 to 55, and you know that it's going to wear off and everything else is stable, I'd probably leave that and not ventilate that patient. I guess what other patients really need ventilating? If you've neuromuscularly blocked them, obviously, if they can't ventilate normally by themselves because they've got some, let's say, intrapleural disease, maybe they've got a pneumothorax, maybe they've got a ruptured diaphragm, maybe there's something like a tortoise or a bird that don't breathe well under anaesthesia themselves, and you pretty much have to ventilate them. But on the whole, most healthy patients will spontaneously ventilate, and then it's a case of tweaking the anaesthetic to find the place that they'll sit happily with their CO2. So I hope that sort of answers that one. But yeah, please do chip in even if you haven't got a question, but you're just thinking, but that's not what I've been told, or that's different, and we can try and discuss some of the difficulties in making these choices.
Thank you, Ellie. And that's all the questions I had on email. Again, this Q&A is for you, opening up to the floor. Please don't be shy. If you want to ask questions anonymously, you can do so. So it's the speech box at the top right hand corner with a question mark. Whilst we wait for those to go through, Ellie, I don't know, did you want to do maybe the different sort of views that you see on the Capnograph? If you've got a drawing program we could try, or
yeah, we can I mean, we can review some of these. I've perhaps got a couple of videos which I was going to add to. I mean, the Becky Robinson's webinar is comprehensive. I've got a couple of different videos just to show for amusement whilst we're waiting for any questions, if anyone has them. So let's see. You can shout out on questions if you want to see any of these that I'm not planning on showing, by the way.
And also, don't forget, she's it doesn't necessarily have to be about capnography. You know, any anaesthesia or certainly sustainability. If you ask Ellie a sustainability question,
you'll get hours.
You will get hours of
I'll try and limit it. We will be doing a sustainability webinar at some point as well.
But certainly, as I say, I'm sure Ellie's happy to answer questions on any of the topics. She is here for you, so please feel free to put any questions of those.
I say you guys are saving me from you know, creative play with the kids, so this is by far a preferred option at the moment. Becky, I was gonna say as well, I mean, you and I do a lot of these capnography and monitoring tutorials out in general practices. What's your sort of sense of, let's just get this out, what's your sense of what people need or struggle with or the most when we or get out of the webinars when we do them, not webinars, live seminars when we do them at lunchtimes?
Yeah, I think personally is like from going from the sheet of Becky's of what the different sort of capnographies look like, and what troubleshooting sort of you would be looking to find out what was causing that capnography trace, as it were. Certainly we've got a couple come in. I'll let you if you want to do the video while it's up, and then the questions are coming now, so that's good. Thank you.
Questions and videos. I'm liking this already. This is a little terrier dog. You can see this capnogram. You can see they've got an ECG here, a pulse oximeter here. We've got a temperature here. Non-invasive blood pressure is not working. And here's our capnograph in white here, and we've got an end tidal CO2 value, and actually here we've got an FI, fraction of inspired CO2 as well. And you can see the baseline is here, and the CO2 when it's going down, which is when the dog is not breathing out, breathing in, is not reaching zero. So this patient is by definition rebreathing. It's not a lot of rebreathing. You probably need to get to a little bit more than that to really affect the end tidal CO2 a lot. But quite frankly, if the FI is above baseline and your end tidal CO2 is going up, and this is going up, then probably the two are linked. So anyway, so this is a little terrier dog. And this dog has nothing wrong with its respiratory system, but it is breathing like a little terrier. And its end tidal CO2 is quite high, so it's not managing to clear its CO2. So eventually I got fed up with this one and started breathing for it. And you can see straight away the capnograph comes down to zero. So this is telling me that you can't quite see the baseline, it is here, it is coming down to zero, very close anyway. It tells you that the patient was rebreathing in part before because they were panting, hyperventilating. So that means they're just shunting the dead space, the gas in the trachea that doesn't really get involved with gas exchange. So they're just moving this gas back and forward in the trachea and not actually managing to breathe the CO2 out. And in that situation, what can happen is they don't breathe the anaesthetic agent in and they don't stay asleep. So this is an occasion where I think I eventually just got fed up of the little dog panting. Sometimes they will pant and the CO2 won't be particularly high and they'll stay asleep, and you just put it down to terriers. That was a case that I ended up ventilating. You can see really nice cardiogenic oscillations on that one.
I was just going to point that out.
Oh, sorry.
That's all right.
There's an indication there of the dog sort of fighting my ventilation a little bit. He's trying to breathe over it. Actually, sorry, just another interesting set point thing there is that when you are breathing spontaneously and you are conscious, your set point for CO2 breathing is between 35 and 45. That is a normal CO2. When you are under anaesthesia, you've been given a respiratory poison that changes your sensitivity to CO2. So suddenly you think your body thinks it's okay to breathe and maintain an internal CO2 of 60s instead of 40s. So the set point changes due to the drugs that you have given. So sometimes when you ventilate them, they stop trying to breathe because you've brought them down below your set point. Even if, I'm ventilating this dog to 50 or so, it stopped trying to breathe because his set point has gone up to 60 or something because of the drugs. Interestingly, actually, I've just noticed in this video, after all this time, Becky, the heart rate comes down on this dog when you start breathing for it. Maybe because it's more asleep.
Yeah.
Maybe because it's high CO2 and tachycardia. Who knows? Okay, sorry, stop blathering.
That's fine. We've got questions coming in thick and fast now. So
excellent.
First one up.
Questions, and then I've got another video. I've got my favourite video, Becky.
Is it the horse one?
It's the horse one.
There we go. We look forward to that.
Okay.
So what does a long inspiratory phase mean?
Okay, so let's go back to the capnogram here, normal capnogram. So just to clarify again, when you start breathing in, your CO2 drops down because when you breathe in, there shouldn't be CO2 there. I hope that's kind of obvious. So this steep drop is the start of inspiration. And then this phase here is inspiration. And then inspiration stops about here. Actually, you can still see we're at baseline, but it stops about here. And then we start to breathe out. And when we start to breathe out the dead space gas first, which doesn't contain CO2 because it hasn't been involved in gas exchange. So start of exhalation. Actually, I don't like calling it an expiration because that sounds like you're expiring or dying. Anyway, exhalation starts here. You start breathing out the dead space gas, and then you get a big dump coming out of very fast of this CO2 laden gas from the alveoli, and most of it comes out pretty quickly, and then there's a little slow upstroke here, and you get that because the last little bits of CO2 coming out are coming from different places in the lungs, so it takes them a little bit longer to come out relatively. So the majority comes out pretty quickly, and then you get a slow upstroke here. So this up to here, this point here, is exhalation. Boom, down here, inspiration, 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 up to here. So we would call this inspiration, this exhalation. And if we think how we normally breathe, how the normal pattern of breathing is, and this is really important if you ever take over ventilating your patients, we breathe in, we breathe out, and we take a pause. We breathe in, we breathe out, and we take a pause. So this is the exhalatory period. And I guess really this is the rapid bit of exhalation, and then you at some point around here you start getting this exhalatory pause that we were talking about, and that's when you often see the cardiogenic oscillations if that's long. This inspiratory phase, I think the question was, what's the inspiratory pause, wasn't it? That would be if you have a pause here, and it's more that if you have a slow phase, let's say through inspiration. Most animals will breathe in at a rate of between about 0.5 and 1 second. So you take breath in over about 1 second, breath out more or less about the same, and then you have this pause. So the whole expiratory period, the active expiration and the pause, is about 2 to 3 times the inspiratory period. The mistake that you make, and we all do it, is when we're ventilating the patients, we breathe in, hold the breath, and breathe out, breathe in, hold the breath, and breathe out, and breathe in, and we sort of reverse the patterns because it should be breathe in, breathe out, take a pause. And the way I make myself do that is when I'm ventilating a patient, I squeeze the bag, I release the bag, and I take my hands off to like stop myself from interfering in that pause time. So that is the inspiratory pause. I would say it's the inspiratory period. I suspect there was something in the webinar about the expiratory pause being when you get cardiogenic oscillations. Was the question maybe reversing that? I don't know. Feel free to chip in again, whoever put that question.
A couple of questions, but they sort of link in. So one on the last video, Ellie, of the little dog panting, they've said, how often did you ventilate between each breath? I've seen this with little dogs and pios. I raise the dog's thorax slightly above the abdomen to help with pressure. And then a second question with that as well, how do you know how many breaths to give?
With that dog, I took over ventilating entirely. What was the first part of the question again, just so I understand? The first line.
So how often did you ventilate between each breath?
I ventilated the CO2 down, and then the dog stopped breathing because I brought the CO2 down below the dog's set point. It still wasn't normal, but it was below where the dog wanted to breathe. So the CO2 came down from the 60s to the 40s. So I guess I gave more or less about 10 breaths a minute. So there's a rule of tens in my head for ventilating, and that is more or less a patient needs about 10 mils per kilo at tidal volume. They need to breathe at roughly 10 breaths a minute, and they need a pressure of around about 10 centimeters of water. That's my rule of tens. There's other things that break that rule that make me unhappy, but those are my tens. So I usually aim for that sort of vicinity. If you're not sure where to go for a particular patient, 10 is a good place to start. Or you think, if this patient was in front of me asleep, what kind of rate would they be breathing at? And that's what you then try and mimic, more or less. So you're aiming for that resting respiratory rate. And sometimes when you give the odd breath, they will continue to breathe around it. But then your question is, why are you hyperventilating? Are you painful? Are you light? Have I fixed all of those reasons for hyperventilating before I try and control it? In this dog, I think it's the terriers. And I agree, sometimes they're hyperventilating because the only way for them to breathe, if you think about patients, what they're trying to achieve is a minute ventilation, actually not on a breath by breath basis, but over the minute. The body cares how much CO2 is in it over that sort of time scale, seconds to minutes. But so what the body is trying to achieve is roughly 200 mils per kilo per minute of ventilation. And it does that by breathing at a certain rate with a certain tidal volume. And it'll change those two parameters depending on many factors. So for instance, if you, in his rule of tens more or less again, if you're breathing at a rate of 10 breaths a minute with a tidal volume of 10, and then you get an pneumothorax, which reduces your ability to breathe in 10 mils per kilo tidal volume, then you have to increase your respiratory rate in order to maintain the overall minute ventilation. So some patients, if they're fat, if they're pregnant, if they are tilted head down, so the abdominal contents are weighing on the diaphragm, all sorts of reasons why they might not be able to mount a normal tidal volume. And in that case, then they may need to breathe faster and shallower in order to maintain the overall. The time that you see the flip of that, when you get a low respiratory rate and a big tidal volume, is when you've given medetomidine. And so sometimes in these panty puffy dogs, I'll give a microdose of medetomidine to just see if I can change their respiratory pattern, make them breathe deeper and slower. And sometimes that helps to settle the anaesthetic depth because it's a sedative as well, and it's an analgesic. So what was the end part of the question? Did I answer it?
Yes, I think you have answered it, because it was, yeah, how do you know how many breaths to give? So, right, next question. I've only been qualified for a couple of years and I did not train with Capnograph. I've been at a new practice and they have a Capnograph. How should a beginner start with Capnograph? I want to be friends with it, not scared of it.
Yeah, and I think this is totally valid, because the problem with it is because it's so non-specific, you can put it on and just be totally freaked out by it. So I would say that if you're 2 years in practice, you probably have done a fair number of anaesthesias. And I hope you're sort of nodding, going, yeah, I'm reasonably comfortable doing anaesthesia in my practice, with my protocol, with my vets. And if you're not, reach out to us, because we are looking to provide training. So Becky Timmons is your person to get in touch with, and she'll give her contact details as well. But if you're reasonably comfortable with your anaesthetic as it is, then hook up your capnograph, but carry on doing things as you're doing them. And just have it running and print off this sheet this understanding capnography sheet and look for the normal. It's like an ECG. Look for when it's normal and pat yourself on the back and be pleased with yourself. And then when it's not normal, start to look at these sorts of capnograms and go, is it any of those? You know, do any of these make sense? If it's high or low, do any of these sort of fit the bracket of what it could be? And then if you don't know at that point what you're dealing with, if it looks different than this, then you've got three options. One is to ask somebody in your practice who's more experienced with capnography. It's highly likely to be one of the nurses. Apologies for any vets who are on the line that are good at capnography. So ask somebody who's got more experience with capnography in your practice. Number two is to email somebody from Davies, one of the anaesthetists, and you can do that via Becky Timmons, or I'll give my email at the end of this session, because we love looking at capnographs. So we're more than happy for you to say, I have this dog, it was this situation, and I got this capnograph. What on earth was going on? Your third option is to visit the amazing...
I wondered how long it would take you.
Sorry. Capnography.com. Oh, go on, play the emboli video. Okay, I'm assuming this is going to... So capnography.com was set up by a medical anaesthetist. So some of the capnographs are specific to the kind of surgeries and the kind of situations you get, but there is an encyclopedia on capnography.com of interesting capnograms, and they show you not only what kind of capnograms you're going to get, but why you're going to get them, and there's lots of interpretation. And I mean, this website is incredibly extensive. So mostly if I'm looking for a capnograph for a webinar, I go to the encyclopedia page and look it up and sort of see, well, did it look anything like that? So for instance, thromboembolus, I was going to show this one anyway. It's showing you if under a normal circumstance, I don't think I can pause it. Yeah, if I press it, I pause it. Under a normal circumstance, you've got a bit of a gap between what you would measure in your blood and what you measure as the end tidal CO2, and that's normal. But if you've got a thromboembolus stopping the blood getting to the lungs, you get this acute drop, and so this gap between the two increases. So the way to diagnose a thromboembolus is to take an arterial, actually a venous would give you a pretty good idea as well, CO2, and map the difference between your end tidal CO2 and your arterial or venous CO2. And if there is a big difference between the two, then you've got an embolus, assuming your patient hasn't arrested. So sometimes when we see this in clinical practice, we document that, we make a good guess as to, based on the clinical situation, as to whether it's an air embolus, a fat embolus, a cement embolus. Fat emboli are common in amputates, as are air emboli. So if we're doing a spinal surgery or an amputate and we get this picture, most likely it's because of an air or a fat emboli. And if it resolves over the next half an hour or so, it was probably an air emboli. If you have a cement emboli, obviously the cement doesn't absorb, and so those can be a bit more challenging. If you've got thromboemboli happening during surgery, then that usually indicates that your patient is hypercoagulopathic. So get that the right way around. So they're more likely to clot, in which case you need to potentially look at treating those patients post-operatively, because surgery will also sometimes produce a hypercoagulopathic state. So these are all things which feed into how you're going to manage that patient post-operatively as well. Becky, I've gone off on one. What was I talking about? Oh, how do I get to be friends with it? Yeah. So those are your three sort of starting places. I think just stick it on your patients as you're doing routine anaesthetics. Don't change anything else. Get familiar with it, and then you'll start to see, oh, that's cardiogenic oscillation. I know about that. Oh, that patient, I've just given another dose of propofol because he was moving and he's stopped breathing so well. Okay, yeah, I've seen that before. Or I've just done a BAL in an asthmatic cat and it's gone like this. At which point you're going, oh, it's possibly had some bronchospasm. Okay, we might need to treat that. So you know, you just start putting it on without making any challenges of yourself or assumptions of yourself, and then when you start seeing anything that doesn't look exactly like that, then you think, it could be something else. So don't feel frightened of it. Stick it on and start using it, and you'll quickly find that you're the practice expert in it, I'm sure.
Thanks, Elliot. And we have had someone say, how can we access the sheet that you're showing us? So along with, we will publish this talk that Ellie's doing today, and there's also Becky Robinson's CPD on capnography as well. They're all available from the Davies website, and you can download the sheet and print it off and have it in your prep room as well. So that's where you can get it from. Next question, is capnography expensive to have in practice, as it seems so vital to have? I wonder why every practice doesn't use it.
Is it expensive? I think yes is unfortunately the case, but not that expensive. So you can get I think we were looking at Mindray IMEC multi-parameter monitors for about, is it in the region of £2,500 to £3,000, depending on your supplier, and that'll be a multi-parameter monitor that gives you everything. And if you're doing anything, anything where you could be potentially doing sick surgeries, I would say that these are valuable things to have in the practice anyway, and they should be just, you know, like an X-ray machine. If you're doing it, you need these machines. The thing to bear in mind is that if you look at the cost of oxygen and isoflurane over the course of a year, if you are not using a capnograph, you have to assume that the patient could be rebreathing, particularly when you're using T-pieces, and you will be a lot less confident in using lower flow anaesthesia if you do not have a capnograph with a circle breathing system. So you will end up using a lot more oxygen and a lot more CO2. And I think I worked out in the past that you can more or less save the cost of the capnograph in a reasonably busy practice over the course of 6 to 12 months. So I think it's a quality, it's an environmental, it's a staff training and staff confidence, it's a reputation, it's a safety thing. It's also actually a health and safety thing, because if you can identify leaks in your breathing systems as a result of or do you have leaks in your breathing system, or like the cuff deflating or equipment malfunction or maybe accidental extubation, then who gets the gas in the room? It's the anaesthetic operator, whether that's a vet or a nurse. So it's actually a health and safety issue to be able to spot these equipment malfunctions coming up. So there's all these reasons for doing it. I think we should stop looking away from exactly it's just a cost thing and start educating our vets as to the quality improvement, the money that they're going to save using a capnograph. You can get handheld units which are probably about half the cost, which will give you pulse ox and capnograph. And that's pretty valuable. You know, if you look in the SEPSAF data, pulse oximetry was one of the key monitors that reduced mortality in small animal practice. So had to have a pulse ox and a capnograph at least is pretty good. So I think you know, hopefully I'm going to give you ammunition to go back to your practices and say, yeah, well, actually we do need capnography. It's a standard of care. As I said in the medical guidelines, you anaesthetise a patient, a human, you have capnography. It's mandatory.
Thank you. When apneic, how long do you leave before needing to ventilate or give a breath? When training on induction, we were taught to hold off to allow the CO2 to trigger a breath, but my new practice is keen to start breath straight away. What is best?
I think it's very much based on the situation. So let's imagine a situation where you have just induced anaesthesia, and let's say you haven't pre-oxygenated, so the patient's been breathing room air, and they were deeply sedated with medetomidine and butorphanol, and you've induced anaesthesia with propofol. Now it's going to, with the best will, it's with a low cardiac output because of medetomidine, it's going to take a few minutes for that patient to redistribute the propofol and reduce the effect on the brain and the respiratory centres. So if your patient has become apneic after induction of anaesthesia, the chances are they're not going to breathe for a little while. And if they've been breathing room air and they don't breathe for a little while, the CO2 can rise to the point where you end up essentially breathing a hypoxic mix. And so their saturation, pulse oximetry, oxygen saturation can drop. And drop significantly, and that's the thing that we used to affectionately call the propofol blues after induction of anaesthesia, where they go just a little bit bluer than you'd like, and that probably is as a result of becoming apneic and becoming hypercapnic. So in that situation, breathing for them is sensible, but at some point one probably doesn't want to have to spend your whole working epoch ventilating a patient that doesn't want to be ventilated. And in many patients, if you are determined that they are going to have a CO2 between 35 and 45, they will not breathe for themselves, and you'll spend the whole anaesthetic ventilating them. And so at some point you want to see where is your set point, because if your set point is 46 or 47, then I'm going to let you breathe for yourself and let it be there. But if I continue to ventilate you and bring you below your set point to 40, you're not going to breathe. So you've got to make a sort of clinical decision about where it goes. So I would say, on the whole, you can afford to wait on the basis that the patient remains asleep, because that's another reason, particularly at the start of anaesthesia, for ventilating them, is to get the anaesthetic gas into them when they're not breathing. So if you're reasonably sure that they're not going to suddenly wake up on you, and they are saturating okay, so either if you have a pulse ox, you can say that the SpO2 is over 95% would be adequate, or if they're looking nice and pink, if you don't have a capnograph, a pulse oximeter, then I think that you can potentially wait a little bit and see when they're going to breathe themselves. But at these time points where you've just given a potent drug that's going to stop them breathing, you know, it's no great surprise that they've stopped breathing. And let's say if you're doing an anaesthetic for a spay and they've reacted to the stump being ligated, the ovarian stump being ligated, and so you've given a dose of something, let's say fentanyl or propofol or whatever you use, and they've stopped breathing, and so then you think, well, I'm not going to ventilate them because that would be really bad for their cardiac output. I'll just wait. And then, of course, by the time they start breathing again, they haven't been breathing isoflurane in for a while. The vet goes for the second stump and they jump off the table. So I think you've got to judge it a little bit, and I think that you can be guided by people's experiences, and there are shades of grey. So it's not so much a right and wrong and best and not best. It's what you're doing and where you're at and what your safe parameters are. So as long as they're saturating okay, the CO2 is not heading much above sort of 60, 65, and the patient's not very light, then I think you're reasonably safe to ventilate.
Thank you. We've on the last question as well about cost of capnography. We rather helpfully have our procurement lady listening into the talk.
Oh, who's that?
Karen.
Oh, Karen. Oh, hi, Karen.
Yeah. Oh, Davies on, yeah. So just to let you know that you can actually get the handheld capnographs for about 800. So certainly a cheaper option, absolutely. So
yeah, you'll make your money back, no problem.
Brilliant. So next question, is there an anaesthetic inhalation agent that is kinder to the environment that is being made or on the market other than sevoflurane?
This is like a whole extra webinar. Just going to show you something if I can find it, not that one. The short answer is probably sevoflurane. This is the one I want. This is the same slide that I showed you before, but this time I've put Tiva in. I'm not suggesting that everybody switches to Tiva overnight. I'm just remarking that if you're looking at an iso and nitrous based anaesthetic, it's about 70 kilograms of CO2. If you take out the nitrous, it's going to be about half that. If you switch to a Tiva based protocol, you're taking it down to less than a tenth of an iso nitrous protocol. So just in terms of carbon dioxide, then Tiva is definitely, but you know, you can head towards Tiva, and in fact, Becca, we should put up the link for the environmental one that we put you know the one I mean on the website.
Yeah, we'll do.
What's it called properly? The blog on how to do environmentally sustainable anaesthesia. It's on our Davies website. I didn't put the link into this because I didn't think to. But the problem with these drugs is, and I'm trying to find out about this, we don't entirely know what becomes of the metabolites of these drugs in the environment. So they may not be entirely benign. We know that propofol is very ecotoxic if it gets into water systems, as you might expect, because you can pour alfaxolone or drugs like that into water and anaesthetize what are they called, axolotls and fish and that sort of thing. I think getting rid of nitrous is a big step forward. Isoflurane definitely has a higher carbon impact than sevoflurane. Oh, how do I get rid of this now? But you can make such big gains by simply reducing your fresh gas flow. So let's say you commonly work at 4 litres a minute with oxygen, and by this webinar you're happy now to go down to 2 litres a minute in most situations, then you've made a 50% saving on your inhalational agent. The other thing that's potentially in the pipelines is recapture of anaesthetic agents. I'll do a separate sustainability webinar, I think, Becky, on this sort of thing. But there is the technology commercially available at the moment, and we need to get the veterinary license for it. So we're working on that to recapture the volatile anaesthetic agents, ISO and SIVO, in what looks like a passive scavenging charcoal canister. You send it away to the manufacturers, they distill the agent out, and then they send it back to you in a bottle for reuse. So that technology should be on the market within the next few years. But at the moment, I think the best bet is actually to carry on what you're familiar with and reduce the flows to a safe minimum. If you're using sevoflurane, then sevoflurane definitely is more environmentally friendly, but you have to bear in mind that there are these data sheet warnings about going down to very low flows, and in the States they've defined that as, I think it's more than less than 2 litres a minute for, less than 1 litre a minute for 2 hours, something like that, over as an average. And I don't know, we don't have the strong science to say that we probably can go less than that for longer times. I think it probably is safe, but we need to find out. And there's also the concern about the cost. So if you're looking at a bottle of sevoflurane, Karen probably knows better than me, but it's going to be in the region of 160, 180 quid a bottle with Sevo, and you need more of it because it's less potent compared with 20 quid a bottle for ISO. That sort of region. So I think that switching to Sevo overnight is something that would be great, but I'm not sure that it's pragmatic. But I think we'll do a separate seminar on that.
Yeah, no, that sounds good. You may sort of cover that in your separate seminar. So if we're going to head away from using inhalation gases, what other options do we have available to us? So cover that on another talk.
Yeah, I think so. Because I think it's a big ask to be switching to TEVA overnight. Although that we can certainly, if you read that blog as a starter, it's on the Davies website. It gives you some good tips for things like pre-medding better. Using drugs that allow you to reduce your volatile agent, using nerve blocks, using better analgesia. These are all things which will make your lives easier as an anaesthetist and make it more pain-free for your patients. And so there are some good options that you can go to without going wholeheartedly into propofol or alfaxolane CRIs. But there's loads of resources for doing that. If anybody that lived through the isoflurane shortage of 2019 will remember that we had to adapt pretty quickly then, and we did pretty well. But I mean, we were looking at the carbon footprint for Davies. We reduced our ISO usage in 2019 by about 1/3, and that's just through doing the low flow stuff. We were already reasonably low flow, but we're just reducing. Low flow is a strong word. We were minimising the flows to a safe minimum. There you go.
A couple of questions on FiCO2. So please, can you explain FiCO2 and what value of it is okay? If everything else seems okay, and at what value would you take action?
Okay, so your machine will commonly give you a number, end tidal CO2, which is this point here. It reads it from that time point, so that will be your end tidal CO2. And then the machines will give you a fraction of inspired CO2, which is like inspiratory CO2. How much are you rebreathing? FiCO2, F capital F, little I CO2. These nomenclatures were decided like eons ago, and they're just standard now, and it's very difficult to change them to something that seems more pragmatic to us. So anyway, you'll have EtCO2 and FiCO2. I think we had it on that video. Where's that video gone? EtCO2, FiCO2. There's the CO2 part. And that's a respiratory rate there. So your machines will commonly give you this number, and it'll get confused every now and again because you can see there's so much variation in this respiratory rate that every now and again it'll read the end tidal CO2 as down here and the Fi up here. And so you have to interpret these numbers with some common sense. How high can you go? Let's say you know that your sodium lime is exhausted in your circle breathing system, and your FiCO2 is going up by 1 millimetre of mercury every 5 minutes, but you also know that your surgeon is starting skin closures, then you're probably going to sit tight with that FiCO2 and change the sodium lime at the end of the anaesthetic. In my experience, you can have sometimes FiCO2s up to 10 millimetres of mercury, and you don't seem to be getting an increase in end tidal CO2 in that situation where your sodium lime is getting exhausted. So you can sort of sit tight on it and think, oh, that's because X or Y. The other situation which you can't change very easily is if you've got excessive dead space. So this would be equipment dead space as a result of a long ET tube So by equipment dead space, Becky, got my diagram here. Going to do some drawing.
It would have been a shame to waste it.
It would have been a shame to waste it. Here we go. Let's get rid of that. So if you've got a, where's the squiggly? We need the squiggly line. There's the squiggly line. If you've got a circle breathing system that looks something like this, and you'll have to bear with me here, and you've got your patient. I have the patient is always an I for me. I don't know why, but that's your patient. And let's say this is your circle breathing system, and you now will all have your capnograph adapter attached to it because you are now totally sold on the idea of capnography. So there's the capnograph adapter, and then you've got your ET tube attached to here and going into your patient. So let's hope that your patient is actually somewhere near your breathing system. The equipment dead space would be, sorry, I need one more thing. This is the gas circulating. So the gas is going around in circles because it's a circle breathing system, but it's the same for a non-breathing system. The gas is going round and round and round and round. The point at which the gas can interface with the patient is here. So your equipment dead space is from here to the dog's nose, to the point of the nares. And if you think that's logical, because when we breathe, when a dog breathes out, this is when it gets really dodgy. When a dog breathes out, it only expects to breathe out to the point of, the body is only designed for the patient to breathe out at the point of the nose. But when we put a breathing system in, obviously you attach an ET tube, and you've got your ET tube going into the patient's body, like so. So it's the point, from the point of the nares, more or less, to the point where the gas can exchange. That is your equipment dead space, and that is non-physiologic. You have added that in, and most patients will cope with that. But if you've got a patient that's not managing to take very deep breaths, or is hyperventilating, or is just small and not very good at breathing, and this equipment space is too big for them, then you may notice an inspired CO2 that is high. And whether you can physically reduce that or not depends on whether you've got capnograph adapters that are small. You can get some that directly go as an ET tube adapter, and they have a little capnograph adapter attached to them. They're just little wee things like that. So that reduces your dead space. Or maybe you've let the ET tube hang out of the patient's mouth, so that actually the ET tube is coming out over here somewhere. And then maybe that can be reduced by cutting the ET tube down. So sometimes you get an inspired CO2 that's because of that equipment dead space. And then, it might sit at 3-4. The Anderson-Moore's guideline, I think, said, a CO2 of, I can't remember what value they put now, 2 or 3 is acceptable. And I agree. I think, it is acceptable to the point where the patient can't cope. And usually they tell you because their entitled CO2 will go up. So.
Perfect, thank you. What do you do when everything else is normal, but either capnograph isn't coming up with any reading? What could be the causes?
Yeah, that's really disturbing when that happens, because that usually means the patient is apneic, or you've had a cardiac arrest that you haven't spotted happen. So like I said, there's only a few capnograms that I allow myself a minor panic for, and I certainly take rapid action, and I prioritize that patient until I've figured out what the heck's going on. So the classic things would be, and you can go to the if you're having this situation and you're thinking, I don't know, then you can come to this chart and start working through things from start to bottom, from top to bottom. So is the patient breathing? Well, you can look at the patient's chest, or you can give them a breath yourself and make sure that you feel normal compliance of the lungs when you're giving a breath, and that you see the chest rise when you're giving a breath. So that will immediately detect whether you've got accidental extubation, whether your patient has become apneic for some reason. Maybe somebody put a drug in the line and that's just reached the patient, and you hadn't noticed that it had taken a while for them to get their hit of fentanyl or whatever. It'll then, if you give a quick breath, you'll be able to then see what the CO2 is doing. And if you've got a ET tube that's leaking, or you've got a split sample line, or you've got a crack in your breathing system, those things can all cause your CO2 to drop abruptly, sometimes to 0, and then you'll be able to feel whether there's a leak, or see whether you've got a normal CO2 coming out. If you've got a normal CO2 coming out from that first breath, the chances are you've not got cardiac arrest. If you haven't got a normal CO2 coming out from that breath that you give, you haven't ruled it out. But hopefully, if you've got an extubation, accidental, or a leak in the cuff, or a break in the breathing system, or some problem with your equipment, you've diagnosed it pretty quickly because you've given a breath and you've heard a rush of gas coming out of the system and smelt some ISO. it can be cardiac arrest. So your next step is very acute if you think there has been a cardiac arrest. Obviously, one would hope you had some reason to expect that. So if that happened mid an intrathoracic surgery, for me, I would ask the surgeon, can you see the heart beating now? Or you can auscultate. Or if you have reasonable suspicion of a cardiac arrest, you go straight into your CPR algorithm and you don't waste time. If you have a pulse oximeter or an arterial blood pressure line, or you've got your ears plugged into an esophageal stethoscope and you can still hear the pulse going, the chances are you've not had a cardiac arrest. And then that gives you a bit more time to troubleshoot what the equipment issue is, because it more or less is likely to be an equipment issue, or why your patient has stopped breathing. So that would be the acute thing to worry about is, have I got a cardiac arrest? No. Do I think I've had an emboli? No. Is there an equipment malfunction? Has my patient stopped breathing for another reason? But my first thing is to just give them a quick breath using the breathing system, and that allows you to diagnose many of the other problems. And if you get normal CO2 off that breath, at least it's probably not a cardiac arrest, and so you can move on from there. So does that answer your question? Please feel free to type an update if not.
Thanks, Ellie. When ventilating, would you most focus on the CO2 levels and the SpO2 levels, or frequency of breaths, e.g. one breath every 15 to 20 seconds? It's
a really good question. CO2 for me. The chances are, if you are breathing 100% oxygen, so normally we breathe, where's the squiggly line gone? Normally we breathe 21% oxygen. That's what's in air. When you're under anaesthesia, you're breathing 100% oxygen. I don't know why that's comes across. So you wouldn't expect a patient to desaturate once they've been under anaesthesia for 5 or 10 minutes, because their body should be loaded with enough oxygen to keep them going for another 5 minutes or so. And you see this at the end of anaesthesia. If you take a patient after you've turned the ISO off directly away from the breathing system and they're still hypercapnic, they'll be okay with their saturation for 3 or 4 minutes, and then it'll start to drop. So you sort of super loading the body. So allowing a pause usually doesn't cause a hypoxemia. The only time it might is if your patient has respiratory problems, which hopefully you've diagnosed on clinical exam, or you've had an equipment malfunction that you haven't realised, like an accidental extubation, or you're using nitrous oxide and you're borderline providing a lower, because when you're using nitrous, you're providing something closer to 30% usually. Okay, so let's assume that we're not particularly worried about the SpO2 because we're expecting it to be normal under most of these circumstances. Obviously, if it's dropping below 95%, you need to figure out why. So that's with the caveat that you have no concerns about your SpO2. So I don't guide ventilation under anaesthesia based on SpO2, in fact, at all, unless one of those 3 conditions exists. So patient respiratory disease, nitrous oxide use, or equipment malfunction. So most of the time under anaesthesia, what we're really interested in is, for ventilation, is CO2. That's what it tells us about. And so, like I said before, what we're looking at is the minute ventilation, which is a composite of the tidal volume times the respiratory rate. My handwriting in real life isn't much better than this. So what the body, as I said before, what the body really cares about is this minute ventilation. What's the average? And the end tidal CO2 will pretty much be based on what the minute ventilation is doing, and that will depend on what the tidal volume is doing, what the respiratory rate is doing. You can measure the respiratory rate. You can't easily measure the tidal volume without a spirometer. So most of the time we're relying on this to guide this end tidal CO2 to guide us as whether the minute ventilation is adequate. So really, because so many other factors will affect the respiratory rate, the individual patient, the drugs you've given, how busy you are opening packets of things to the surgeons, I'm guiding it based on the end tidal CO2. So I hope that makes sense. Again, please do feedback if it doesn't.
Thanks, Ellie. When monitoring, we've been advised that it's not really an issue until the patient gets 55 to 60. Should we be changing that limit, which we deem problematic, therefore becoming quicker to change our anaesthetic?
I think 55 to 60 is a reasonable guideline. I think the point I would make is that as soon as the CO2 is out with the normal value of 35 to 45, it is not normal. So the question then is, why is it not normal? And if you know why it's not normal and you're happy and comfortable with the patient being stable in every other respect, so let's say it's 55, but my blood pressure is fine. My patient is a brachycephalic dog and it's on its back. It may well have a higher set point for CO2 anyway. Dog's asleep, breathing at a nice rate of 10 breaths a minute with a normal respiratory excursion as far as I can see when I'm looking at the patient. Then I would sit tight on 55 versus a patient that you've induced anaesthesia on and you've maintained anaesthesia and now you think they're looking a bit deep and the CO2 is 55 and you think I'm going to turn the ISO down a bit because everything supports me thinking this patient is a bit deep. So I think it's not an unreasonable number to sort of give you as a sort of sense of if you get to 55 or 60 CO2, what can you do to make it? But you can make those decisions earlier. You can tweak your. It depends what kind of anaesthetist you are, if you're a tweaker or not. But if you think that the patient's too deep and the CO2 is 50, then lighten them up a bit. So I'd exercise a little more of your clinical experience, let's say.
What is happening if your capnograph shows a longer than normal exhalation phase, please, as in longer than inspiratory? Is this okay if everything else is normal?
Yes, short answer. Capnogram. Oh, I think I did one up here. Breathing in, breathing out, pause. Breathing in, breathing out, pause. And so we have this kind of this rhythm, breathing in, breathing out, pause. So usually this breathing in phase, as I said, is about 1 second. This breathing out phase is about 2 to 3 seconds, about 2 to 3 times this, and this is normally about 1 second, so more or less about that. So that's in, that's out. So we breathe in, we breathe out, we take a pause. And the question was, why do you breathe? Why do you have a longer pause? If you're breathing slowly, because when you're breathing slowly, if you're breathing at 5 breaths a minute or 10 breaths a minute, you've got the same speed of in breath, but you just have a longer pause. So you have this active phase of breathing in, breathing out, and then you take a pause. And it's the pause that can be longer if you've got a lower respiratory rate. So if you've given medetomidine or you've given opioids or you're just not breathing very fast. So it is reasonably normal to have a long expiratory pause. It should be about 2 to 3 times the inspiratory phase. And if you've got a slow respiratory rate, it'll go up. So it's just telling you you've got a slow respiratory rate, nothing more.
Thank you. A couple of questions on ventilating. So when ventilating a hyperventilating patient, when do you pick the safest right moment to give a breath so that you don't cause trauma to the lungs? I had a patient recently whose respiration rate was so fast I felt like I really struggled to give breaths at the safe point. And just as a second point to that, we've also had someone say, I've seen people do different things during IPPV, either fully closing the valve or only half closing the valve. Are both okay?
Yeah, I'm going to pick the first one. So in an ideal world, you take a breath for a patient when they're not trying to breathe themselves. So not when they're breathing in or breathing out in these active phases of breathing in or breathing out. Sometimes when they're hyperventilating, you can't match it. So you've got two choices then. One is to take over breathing for them pretty rapidly and bring their set point down quickly so that you then control the breathing and they're not trying to breathe. The other option is to give them some kind of drug which stops them breathing. So in extreme circumstances, there have been occasions where the patient's respiratory efforts have been in the way of what the surgeon's trying to do. This is usually when you're doing thoracic surgery, and we've actually paralysed the patients to stop them breathing so that we can get control of the ventilation. So there's a bit extreme. You can achieve this with fentanyl sometimes, or with ketamine. If they're hyperventilating because they're painful, or because maybe they're hyperventilating because they just need more anaesthetic agent, and you can give a dose of propofol. You can do that through your IV catheter. So sometimes stopping them from ventilating is the way forward. Other times you might just be able to turn the ISO up and let them hyperventilate themselves back to sleep. So you've got those options. In terms of what's safe for breathing, let me see if I can find this. Oh yeah, here we go. I'll just leave it at this for the minute. So you can see here, this is, sorry, an old presentation, but this is the normal pattern. This is time on this axis, and this is the pressure in the thorax. So when we spontaneously breathe, we actually have a very low pressure change in the thorax here to draw air in and out and in and out. When we start ventilating them, we push pressure into the chest at pressures between 10 and 20. So my rule of 10s, 10 centimeters of water, but you know, up to between 10 and 20. So we're forcing air into the chest. So the question as to the question was about whether you fully close the valve or not. You can do what you like as long as the pressure that the patient gets is not dangerous. And usually we say between 10 and 20 centimeters of water. Now, in terms, I don't know if I've got the photo of, no, I probably haven't got the photo. In terms of the pressure that means when you're actually ventilating a patient, it's fingertip pressure. So if you've got the bag in the meat of your hand and you're giving it a good grab, that's too much. 10 centimeters of water is the same pressure as if you put your finger over the end of a straw and push the straw down 10 centimeters deep into a glass of water. So it's not a lot of pressure. So you're providing fingertip pressure, and you're then looking at the chest and making sure that the chest is not over expanding. So you're looking for the kind of expansion you would get if that patient was asleep. It's actually pretty subtle in terms of how much the thorax moves. And if you're holding the bag in your hand or between your fingertips, and you've got a patient that's 10 kilos and you've got a 500 ml bag, you've got a 10 kilo dog, tidal volume should be 10 mils per kilo, so the tidal volume should be 100 mils. So on a 500 ml bag, that's only a fifth of the bag. So you've got these ideas of actually not a lot of pressure. So if you close the valve and you find that the bag distends and fills very quickly, and actually there's a lot of pressure that you're squeezing into the chest, then that's too much. That's when you might part close the valve instead of fully closing it. Again, just safe practice. Whenever I ventilate a patient, I have one hand on the valve, one hand on the bag. I close the valve as much as I need to deliver a nice fingertip pressure, 10 centimeter water breath. Then I release the bag and I release the valve. And I do the two things in concert always, so that when you take your hand away, the valve should be fully open and the bag should not be over distended. So it's very much based on the pressure changes that you get.
So we've got a few more questions, Eddie. Thank you.
Yeah, no worries.
What is happening if your capnograph shows a longer than normal exhalation phase, please?
Just as straight as before. They're just they're breathing slowly. That's it. They're breathing slowly.
I'm not sure if you can answer this one. Do you have any top tips for using capnograph on exotic species and small furries?
Top tips would be if you have the facility to purchase a capnograph that has a lower sampling rate that's designed for those species. So most of the capnographs that you'll get will sample at 250 mils per minute. And if you're dealing with, let's say, a rabbit who's got a tidal volume, let's say a 2 kilo rabbit is going to have a tidal volume of 20 mils. You can see that the sample rate is going to be a heck of a lot more than the rabbit's tidal volume. So you end up with quite a dilutional effect on the capnogram that you see. So instead of your normal end-tidal CO2 being at 45, it'll almost always read, lower when the sample rate is too high. And that's the same goes for when your fresh gas flow is too high with those species. So some of the capnographs that you can buy will allow you to manually adjust the sample rate down to the lowest possible setting. And ones that are designed for small furries will allow you to do that. I'm pretty sure Vectronics used to sell one, but I haven't looked that up recently. The other thing is to buy low dead space connectors. Oh, I deleted my dead space drawing. So some capnograph adapters look like this sort of thing. One end goes to the breathing system, one end goes to the T-piece, and others are essentially a modified ET tube connector. So they have the capnograph sampling line coming off like this, and it is that the ET tube goes directly onto the sample. So I would use something with a low dead space. I would use side stream rather than, well, this is a difficult one. Side stream one versus mainstream capnography. The mainstream capnographs have a bit of kit which sits over the connector, and it's heavy and it can sort of put a bit of drag on the breathing system. So with the side stream, the problem is you get a delay in your readings and you get this potential sampling error issue. But with the mainstream, I think your bigger risk is that you extubate the patient by accident. And it's a lot of weight on the breathing system and a lot of dead space. So I think probably I would use side stream in those patients. So that would be my tips. But if you can turn the sample rate down, that helps an awful lot.
That's great, thank you. Can you talk a little bit about PEEP? It may be a bit of a topic, but what instances might you use it and what values?
Okay, I go back to basics if that's okay. Becky, I'm just assuming that I'm going to keep going until there are no more questions. So
yeah, I've got one more after this. So
okay.
Yeah.
Well, we can run another webinar on other topics. Let me think. Where have I got best resources for PEEP? Or shall I make it up? Let's make it up. PEEP stands for positive end expiratory pressure. Positive end expiratory pressure. And if we just grab that picture that we had before. Ooh. Oh, sorry, I had to delete my keyboard to make the I want this one to make the plug work. Is that going to work? Yeah, here we go. Now I said that when we're ventilating normally, hopefully we're not using ventilators that give this kind of spike. Most of our ventilators come sort of a bit more shallow, but anyway. So when we're ventilating normally, we this is pressure and this is time on the x-axis. So we push air into the chest and then we release our fingers, or we turn the ventilator off, and the air pressure in the chest comes back down to 0. So at the end of expiration, end of exhalation, the pressure is down to 0. And then we start again. So we push the pressure. So the peak inspiratory pressure, PIP, not to be confused with PEEP, the peak inspiratory pressure is around about 20. And here there is no positive end expiratory pressure. But there are some situations where we want to create a mechanism by which the positive end expiratory pressure is around about 5 to 10. And that would be the normal sort of working values for most of the kind of cases we do in veterinary anaesthesia in small animals. So there are occasions where we might want the positive end expiratory pressure to be sitting around about 5 to 10. I can't make it come to the top. So when might that be? Or what does that actually, how do you achieve that? What does that actually mean? If you think about what it means in terms of the mechanics of breathing, it means that when you breathe in, you breathe into a pressure of, and this is when we're ventilating, we're pushing air into a pressure of 20. And when we breathe out, if we've got PEEP present, we're breathing out, but we're not breathing out completely. We're just holding a little bit of pressure in the lungs at the end of exhalation. So the next breath comes in, goes up to 20, and it comes down, and it never comes down to 0. It always comes down to around about 5 to 10 or whatever you set. And the reason for doing that is that holding that little bit of pressure in at the end of exhalation, holding that little bit of breath in the lungs at the end of expiration, will keep the alveoli stented, keep them open. So you do this in circumstances where you feel that the lungs collapsing at the end of exhalation is a problem. So normally what keeps your lungs open, what keeps them from being atelectic, from being collapsed, is a number of factors. One is that when we're conscious, we take sigh breaths every now and again. So probably, and hopefully not too often during this presentation, you've been taking a deep breath. And when you take that deep breath, it re-expands anything that was atelectic. So that might be a thing that keeps your lungs open. Another thing that keeps your lungs open is that under normal circumstances, you have a little bit of negative pressure in your intrapleural space, that the lungs they're sucked out to the rib cage, keeps them open. So this adds the kind of sense of the lungs being open at the end of exhalation rather than collapsing every time. When you might have a problem is that, for instance, if you're doing intrathoracic surgery, or if you anaesthetize a patient, they stop taking sigh breaths, or if you have an excess of pressure outside the lungs, which is causing them to collapse. So the classic example of that is if you put a horse on its back under anaesthesia, around about up to 30% will collapse in the first 5 minutes. 30 to 50% of the lungs will collapse because of the weight of the horse's guts. The horses have a particularly sloping diaphragm. So if you put a horse on its back, all the guts sit on the diaphragm, squish the lungs through the diaphragm, and you get a load of atelectic lungs. Oh, a nice CT of that somewhere. Can I find it? Possibly not. It's under the pulse oximetry. No, I put it somewhere else. Okay. So you might use positive end expiratory pressure to hold those lungs open in that circumstance. So we commonly use it in patients where we're doing an intrathoracic surgery. In conscious, normally ventilating patients, you wouldn't usually use PEEP. We don't use it that often. In a patient that, say, is obese and is on his back and keeps desaturating, and this is the key, if they become atelectic, the problem that you get then is a desaturation, so your oxygen saturations drop. And the reason that you get that is that the blood is coming into the lungs, but because the alveoli aren't open, there's no oxygen there for them. So they're going out of the lungs, having picked up zero oxygen. And if enough of the blood coming into the lungs meets these collapsed alveoli, then you'll end up with a systemic lack of oxygen. And we measure that as either a drop in your arterial oxygen partial pressures or a drop in your SpO2 if you're measuring that. So this is where we start to say this is a patient with a respiratory compromise. This is where hypoxemia can happen under anaesthesia. So this is where ventilation starts to get involved in VQ mismatching, in lung collapsing, in oxygen as well as CO2. But it's reasonably uncommon during anaesthesia of small animal patients to get that situation. So I've seen it a few times in really big dogs, these fat bull mastiffs on their back, and they behave like horses. Their lungs, enough of their lungs are collapsing that they're getting shunting of blood through the lungs, and that's the technical term for that type of VQ mismatch, ventilation perfusion mismatch. They're getting shunting of the blood through the lungs, not picking up any oxygen, and they're desaturating. And you can fix it by opening the lungs again with some big sigh breaths, recruiting, and adding some PEEP to hold them open. The problem we have if we don't add PEEP in those patients is that you give a breath in, you give a breath out, and the lungs collapse. You give breath in, bring breath out, the lungs collapse. And this continual opening, collapsing can cause a sort of shearing stress on the alveoli, because they're not, apart from when we're first born and we take that big breath to expand the alveoli, our alveoli aren't collapsing that much, because we're continually keeping them open with these sigh breaths and such. So they get a shearing stress on them, which causes inflammation, and you can actually get a ventilator-induced injury. So this is what, unfortunately, a lot of these COVID patients will be receiving PEEP because when they're ventilated, because they don't, humans are very susceptible to lung injury, and we probably don't do that kind of long-term ventilation enough to see the problems. So I think if you're doing the majority of the people we're talking to here, I'm imagining a GP practice, PEEP is not something that you need to worry about. It's something that we do when we get to referral levels, but it's really interesting. So we can do a VQ mismatch shunting seminar at some point if people have an interest in it. There you go.
Thanks, Ellie. And one final question. What certificates or courses would you recommend for RVNs who are interested in anaesthesia?
How much do you want to say on this, Becky?
No. Go. I'll leave it to you.
Well, just, we've been discussing it, haven't we, Becky?
Hinting, yeah.
Okay, we can hint that we are trying to make such a basic anaesthesia course available. We're trying to accelerate its availability because of COVID, and obviously the opportunity to train people and come out of this whole situation, awful situation, in a stronger and better place. So if we can, if we have interest in that kind of course, if you could email Becky Timmins directly. And if you don't have her email, then I've put my email at the end of this presentation, so you can email me, and I'll put you on to Becky Timmins.
But it's certainly something we're wanting to really sort of get in sooner rather than later, I think is fair to say.
So we want to put that kind of basic anaesthesia course out there. In the long term, we would hope to get that ABA accredited, but obviously things are all changing at the minute. There is a VTS course which runs remotely from the States. I think you have to go there for the final exam, which is often what people do. There are diploma nursing courses, as you know, that will include anaesthesia. We do have some people come to see anaesthesia at Davies as well, but we find on the whole that it's especially for GP practices, we are more successful in creating meaningful change if we come to your practice, and we can do that virtually now via webinars, and actually talk to your whole team, because what we find is that if we say to one person you should do this, it's really good, and convince that one person, and they go back to their practice and they can't convince anyone else in the practice because everyone else is saying, well, I don't know, and they want to ask their questions but there's no one to ask. So if you want to arrange that kind of virtual webinar for your practice in this downtime, please contact Becky Timmins and we will certainly facilitate that. And yeah, as far as I know, for actual kind of validated courses, Becky Robinson might know some more, but we're going to put an FAQ document together, so I'll have a dig around and see if there's anything else running. But in the meantime, like I say, we want to run something through Davies virtually as a organised course with tutor support during this crisis. If you're interested in that, then please contact Becky Timmins.
Thank you, Ellie. Because we did promise it, I think it's only fair as for anyone who's not convinced, although I think you're there why you should have capnography. Seems only fair to finish on the horse video.
Okay.
We did promise it.
Yeah, I really like this one. Actually, there's two. Can I show the bundle branch book as well? I like that one as well.
I think it's only fair.
Okay. Just wanted to highlight, these are the resources. There are hyperlinks on these resources, and we'll put out the deck on the various channels afterwards. Again, get it from Becky Timmins if you need it. Those hyperlinks should take you to, there's a set of COVID anaesthesia resources, which include some TIVA resources that BSABA have put out. The Association of Veterinary Anaesthetists are constantly posting things, and they've got all of the Davies stuff, and we've got the Davies stuff on the Vet Specialists website as well. And if you have any questions, then that is my address. Now let's find these beautiful videos. This is more or less the same as Becky Robinson put out in her seminar. I don't know what obsession we've got with showing you horses. I apologise for that. I think it's because so many septic horses get euthanized. Oh, actually, I've got a septic dog there. I'm going to put the dog up. It's going to play. Okay, just pause it to start with. This is a dog that is very hideously septic. What I find fascinating about this is the ECG looks pretty normal and is a pretty good rate. The pulse oximetry is also pretty normal and pretty good rate, a pretty good number. The arterial, this is, I promise you, an arterial blood pressure trace. This dog is receiving noradrenaline, and you can see that the mean pressure is still 35. So this gives you some indication of how cardiovascularly sick this patient is. And the fact that the CO2 is not between 35 and 45 probably gives you an indication that in this case, we've got a reduction of CO2 due to hypometabolic state, which is not that common. And to be frank, you know this dog is sick before you take it to anaesthesia, so you've got a good assumption as to why that's low. But you've got a normal capnogram shape there. Okay, and I'm euthanizing this patient. So the trick is to look at this set of monitoring equipment and say to yourself, which is the first one that's telling me this patient is dying? Which is the first one of these machines that starts to say, yeah, this patient is dying. And I'm ventilating this patient, so if you were euthanizing a patient like this and you gave Euthatal, they would stop breathing. So actually you wouldn't get this neat stepwise reduction that you're starting to see in the capnogram here, and coming down millimetre of mercury each with each breath almost. These are all still looking pretty good, and they will do for some period of time. Now, anybody that's worked with pulse oximeters knows that they're notorious for alarming at you and telling you your patient is dying. And I actually think one of the reasons that pulse oximeters are so valuable is that they complain so much that it makes you go back to your patient and actually check your patient. Just to give you the same sort of thing, this is a horse, but where we've got an arterial blood pressure that's registering. So again, it's a weird ECG, but this is a normal QRS complex for a horse. And again, we're euthanizing the horse, and you can see we've got an invasive arterial line here, but we've got a normal mean arterial pressure of 78. So that does start to drop when the horse starts to die of the Euthatal that I'm administering. But what you'll see sooner is a drop in the CO2, and it is that stepwise reduction that you get breath to breath. And again, I'm ventilating this patient. If I wasn't ventilating them, you might just see a drop to apnea when you give euthytal. But actually, often in spontaneous cardiac arrest, you'll see this, they keep breathing for a little bit of time. Had it most recently in an English bulldog, just so vagal that it arrested. That was fun. When are you going to start to, I can't remember when I've given the euthytal on this one. I think it's quite soon. There we go. So here you are starting to see it on the invasive arterial line reasonably soon, but you have to ask yourself how often you're likely to put an invasive arterial pressure line in, and versus how often you're relying on your ability to detect a pulse with your fingers, or an invasive blood pressure monitor, like an oscillometric machine, which measures every 3 minutes, and if it can't get a reading, says unable to get signal, and then you press the button again, and 3 minutes later down the line, the animal's well gone. The last one I want to show you. This is a patient with pulmonary stenosis, pulmonic stenosis, and we're doing a balloon dilation. So this is not a GP procedure, but it highlights something rather interesting, I think. So this patient, I apologise for the quality, this patient has an abnormal QRS complex, but whatever electrical activity it's producing is producing a pretty good arterial pulse waveform. The mean arterial pressure is around about 70. Great capnograph. You've got nice cardiogenic oscillations there. Your pulse ox is reading, perfectly. So this is a right bundle branch block. It will produce a normal cardiac output. So that's fine. So the ECG looks a bit weird, but it's doing its job. Now what we're going to do as this video runs is we're going to put a balloon catheter into the pulmonic outflow, which is the main outflow tract from the heart to the lungs, and we're going to block it. And the reason we're going to block it is to try and pop open the stenotic valve to fix the dog's disease. So we are going to temporarily occlude all cardiac output in this dog. And when this happens, you're going to see that the arterial pressure trace drops to 0 because there's no blood coming through the heart, because we've stopped it. You may see some arrhythmias happening because the heart generally doesn't like this happening, and so complains with some arrhythmias. But what I want you to look at is the end tidal CO2. So let's run this. You can tell when we start ballooning because the pressure trace will drop down. If the video doesn't freeze, there we go. Okay, so it's dropping down now. So breath to breath, we've already seen a reduction in the end tidal CO2 height here. This is a spontaneously ventilating patient. So this is what I mean by the ventilation will sometimes continue and give you that clue as to arrest. And as soon as you've got pulsatile output come back, CO2 comes back up. And there go the arrhythmias. So usually we have to say to the cardiologist, please could you wait a few minutes until the heart's a little bit happier. Cool. There you go, Becky. I've shown my favourites. I'm happy now.
Brilliant. Thank you so much, Ellie. That was brilliant. And as Ellie said, we will make this recording available on our website as well. But if you do have any further questions, all our anaesthetists are always happy to sort of answer any of those via email, or if you've sort of via phone, if you've got a case you need to discuss, then please feel free to call in. And anything that I can help with as well. So I will put my email address as well, is available online. So it's becky.timmons, TIMMONS @vetspecialist.co.uk, and there's Ellie's email address. So thank you all for logging in, and we hope to obviously bring you more. And please let us know if there are topics that you'd like us to do Q&As on, or CPDs, because we'd like to obviously put things out there that are wanted. So thank you very much, Ellie.
Yep. Very welcome.